Hi everyone, my name is Nicole Cork. I am the Association Manager of iHEA's activities. Welcome and thank you for registering for today's webinar, Developing Strategies for Effective and Efficient Immunization Against COVID-19. Today's webinar will run for approximately 60 minutes and will be recorded and uploaded on our website afterwards. Before we begin, I just wanted to run through a couple of housekeeping items. If you do experience any technical issues during the webinar, please write them in the chat box at the bottom of your screen and I'll be happy to assist. Everyone on the line has been muted except for the speakers to eliminate background noise. So if you do have any questions during the webinar, please use the chat box and they'll be addressed at the end during the Q&A. I will now pass it over to David Bishai, who will be introducing today's speakers.
Hi, thank you, Nicole, and thank you to everybody for coming. Just wanted to note that this is a webinar sponsored by the Immunization Economics Special Interest Group of the International Health Economics Association. You can find this interest group on the iHEA webpage. Please stay tuned because this is a great group. If you're interested in the economics of vaccines and vaccine policy, this is the place for you. We've also had special support and organizing from Teaching Vaccine Economics Everywhere. This is a group of faculty that offers webinars and courses, and Srina Malavia volunteered her time to help put this webinar together, so we're really grateful to her for that. So let's get started with the introductions. This is an important and timely webinar. The world is waiting anxiously for an effective and safe coronavirus vaccine. But as economists, we know that scarcity is the law of all life on this planet, and we as economists are needing to anticipate scarcity. So our panelists have been asked to address what we will do after there is a vaccine to address the choices and problems that might come as a vaccine has arrived and needs to be allocated. So we're not really going to be talking about the incentives on R&D and development and production. Those are all important questions and are active now. We are looking ahead to a future of having a vaccine to allocate. The speakers are going to give opening remarks for 5 minutes each and then be open for discussions. We would like you to use the chat box at any time you like. You can also unmute yourself if I call on you to say your question verbally. So let me introduce our speakers. Our first speaker will be Anuradha Gupta. She is the Deputy Chief Executive Officer of Gavi and is leading efforts to help Gavi apply its incredible resources to the problem of a coronavirus vaccine. Our second speaker will be Professor Prashant Yadav, who is an affiliate professor of technology and operations management at INSEAD. And he is has been working extensively on healthcare supply chains and designing better supply chains. He's also consulted extensively for the Bill and Melinda Gates Foundation. Our third speaker will be Dr. Anthony Kinghorn, who is a doctor, a health economist, a public health practitioner, and he is a senior advisor to the Priceless Initiative at the University of Witwatersrand in Johannesburg. He's done a lot of research on resource mobilization and financing in low and middle income countries. Fourth will be Dr. Awad Mataria. Dr. Mataria is a health economist at the World Health Organization at the regional office for the Eastern Mediterranean. He will be speaking over the issues in this region on how the EMRO region is working to prepare for a coronavirus vaccine. Finally, Professor Bill Padula is an assistant professor at the School of Pharmacy at the University of Southern California. He is an expert in economic evaluation and cost-effectiveness analysis, and we'll talk about those applications. So let's get started. I'll turn over the floor to Anuradha Gupta, and we await your comments. Anuradha, thank you so much.
So thank you, David and Srina, for this very topical discussion. We are all witnessing the catastrophic effects of COVID-19 pandemic on lives and livelihoods. The global economy is in a tailspin. Estimates of economic loss are changing by the day, now suggesting $375 billion could be lost every month. Inequities have been exacerbated with millions losing their jobs. Between 70 to 100 million additional people are likely to be pushed into extreme poverty in 2020 alone. I would want to emphasize that the trajectory of this pandemic is highly variable between continents, countries, and within countries. However, we see all countries and populations as very fearful and being in a state of flux. Low and middle income countries that Gavi typically supports face exceptional challenges and compounding vulnerabilities because of poverty, inadequate healthcare, and lack of financial stimulus. So the end of the pandemic is nowhere in sight, as all of us are aware. A lot of hope is therefore pinned on a COVID-19 vaccine, increasingly seen as the linchpin intervention to bring this pandemic to a halt. However, given that the global demand for COVID vaccine would outstrip the likely supply in the short to medium term, there is bound to be a scramble, as David said, including bidding wars. There are already clear signs of vaccine nationalism displayed by many governments, which have the resources to get into bilateral deals with vaccine manufacturers or have vaccine manufacturing on their home soil. As nobody's safe until all of us are safe, a global solution is needed to ensure safe and effective COVID vaccines are rapidly developed, manufactured, accessed, and distributed with equity as the key mantra. So you might be aware that Access to COVID Tools Accelerator, in which Gavi is a lead player, was launched under the aegis of WHO about 3 months ago to accelerate development and production of not just COVID-19 vaccines, but also diagnostics and therapeutics, and more importantly, a fair distribution of these commodities. The vaccine pillar brings together Gavi, CEPI, the expanded name is the Coalition of Pandemic Preparedness Innovations, and WHO. CEPI's focus is on vaccine research and development. WHO is concentrating on the policy and fair allocation framework, and Gavi is leading on procurement and delivery of vaccines at scale. I really think that these are all important components of the value chain, and therefore it is important for us to look at all these interrelated pieces together. We hope to intervene effectively in terms of procurement and delivery of COVID-19 vaccines by putting together a global buying consortium, which we are calling the Global COVAX Facility. This facility pools demand from both high and low income countries and offers volume and demand guarantees to incentivize accelerated production and supply of 2 billion doses in the first phase. The aim is to have enough doses to initially vaccinate about 20% of the population in each participating country so that we are able to cover at least health workers, elderly and high-risk populations, besides maintaining an emergency buffer. This mechanism pools benefits, but it also pools risks and provides access to a proactively managed portfolio of vaccines. High-income countries under this facility would pay for their vaccines, and more than 75 countries have already expressed interest in joining this facility. For 90 lower middle-income countries, which may not have the ability to pay for the vaccine, we have launched a separate financing mechanism called the Gavi COVAX Advanced Market Commitment, in short AMC, to leverage development assistance as well as philanthropic and private sector funding. COVID-19 AMC is inspired by similar instruments that Gavi has developed and used very successfully in the past, such as for pneumococcal disease, the biggest killer of children under the age of 5, and Ebola. We thus hope to draw from our expertise and success in market shaping, innovative financing, and at-scale implementation of life-saving vaccination in lower income countries. I would want to pose two questions to this audience. First, how do we use smart economics to develop international consensus on COVID-19 vaccines as a global public good, so that vaccine manufacturers, donors, developing and industrialized countries willingly invest to ensure we all are safe and we don't see an unhealthy race for limited supply of COVID-19 vaccines. For childhood vaccines, we estimate that for every $1 invested in immunization, there is a return of $48 in poor countries. This has helped us build enormous political will in both donor and recipient countries and to encourage them to invest in immunization. A similar economic argument, I suspect, is needed for COVID immunization. Secondly, how would economics help counter growing negative rumors and mistrust about COVID-19 and other vaccines, and enhance public understanding that vaccines are the most cost-effective and safest public health intervention and probably the shortest way to get out of this pandemic? Thank you so much for your attention.
Thank you, Anuradha, and thank you for those two questions for the audience. How can we as economists contribute what we know about global public goods and what we know about demand and vaccine hesitancy under rumors and misinformation? There's a lot of expertise that we bring. Let's ask Prashant to turn on his mic and share his comments.
Thanks, David, and thank you for organizing this. I think, like Anuradha said, very timely and extremely important for the Health Economics Committee to come together and think about what we know and where are areas where we can collectively contribute with research. As you said at the start, David, when we have a problem in which supply is not sufficient to meet demand, we know that aggregating both demand and supply makes it match better, right? So that's almost as good as a law of physics, which means if we pool demand and if we pool supply, in all supply constraint scenarios, that gets us better outcomes, better allocation, better matching. And so it's worth asking the question, are we doing enough on pooling demand? Are we doing enough on pooling supply? Anuradha described some of the work that Gavi and others are doing on pooling demand, which I think is commendable. We do have some countries which are negotiating directly for their purchasing, but for a large part of countries, that COVAX structure is working. If we look at pooling supply, that's where I think there are greater opportunities to demonstrate where we may be losing value by disaggregating supply versus aggregating. Two examples come to mind. One is the idea that you have enough total, let's say, fill and finish capacity for a vaccine in the aggregate. Aggregate meaning you sum up all of the capacity that exists around the world and then look at the cohort of 20% that Anuradha described, then I think we'll be fine. We would have enough. But once you start disaggregating it and saying, here are 5 countries who have the largest installed capacity of fill and finish, if they were to keep more than the 20% or however we come up with the right threshold, then of course we don't have enough supply. So on the aggregate, things would be good, but on the disaggregate, things would actually not work out. How do we make a stronger economic case for keeping the supply aggregated versus disaggregating it? The second item in disaggregating supply side is that each manufacturer or each vaccine developer has contracts for manufacturing capacity with their contract manufacturers, which are contracts that are bilateral between a vaccine developer and a contract manufacturer. So imagine a scenario that a lead vaccine candidate does not succeed. We want to take all of the contracted capacity and put it for the candidate that is succeeding. How do we create such coordination so that the limited manufacturing capacity that we have is fungible, interchangeable, rapidly reconfigured to meet the vaccines which are showing success in meeting the WHO target product profile? So that's a second part of disaggregation, which I think is important to keep in mind. A third thing I want to emphasize is around, are we ready for distributing a vaccine to a targeted adult population? So most of what Gavi and countries have done on pediatric vaccines is, in a way, largely focused on a birth cohort it is harder to do targeting for adult population, right? It was for all adults, it's different, but now we're talking about specific priority groups. And even if we know what those priority groups are, in many countries, there isn't a registry of healthcare professionals so that you know exactly who's a healthcare professional. The cadres of healthcare professionals vary considerably from country to country. So oftentimes there is a registry of trained doctors or physicians, but not necessarily of nurses or frontline health workers. So how do we create that? And then is the question of, is it clear to all of us that the targeting rules will be healthcare professionals and those with comorbidities and high-risk populations first, or are there other rules that will emerge? I think similar to the discussions that the ACIP in the US has had, as national immunization task force in each country start having their own discussions about how will they prioritize, how will they determine the tier 1 group, tier 2 group, which may vary depending upon context and epidemiology. They will need a lot of help from health economists in the countries who know the context to help determine that robustly and with sound evidence. So that's another plea, which is if we can get ready for it proactively before that ask comes, I think we will all be able to help. I'll pause there. Thank you.
Thank you so much, Prashant, and thanks for being so clear and so effective in your use of time. Let's turn it over to Anthony.
Hello, colleagues. I'm going to share a couple of slides with you. Okay. Are people able to see my screen?
Yes.
Okay. When we met as a panel a few days ago, we discussed what we would do if our governments asked us for advice about what kind of strategy we should use to implement COVID immunization that would be most cost effective. And broadly, what I did was I took a country that I'm quite familiar with in the region and started playing with the numbers to try and work out what seemed to be the big issues and what seemed to be the small issues that we'd have to take into consideration in generating that advice. So I've got a country in the area, in Southern Africa, population just over 18 million. And what I did was I looked at different targeting scenarios at different vaccine prices that we'd agreed as benchmarks. So on this slide, you can see on the far left, the vaccine cost, $2 per person, 10 or 20. Then different proportions of the population that fall into different target groups, and then some estimates to the right of that of what the total cost would be for the country to cover each of those groups and how that would stack up against government health expenditure. And so these numbers are very crude, but I think that they start showing us some of the things that may be useful to answer that kind of question, whether it's posed by our governments or partners internationally. So of the 18 million, one of the targeting options was just to cover the whole population. And that leads, especially with high cost vaccines, to a very large total population cost for the country of $368 million. And that would be equivalent to 62% of all government health expenditure, broadly, roughly. And so obviously that starts posing really difficult questions about what to prioritize and what one's actually getting for that level of expenditure. If we go for a crude targeting criterion of people aged over 50, one of the interesting things that comes up in our part of the world in some of the countries is that only about 6% of the population are over 50, which basically is probably around a third of what we see in much of Europe and a lot of communities in North America. And that obviously influences both the effect you're going to have through your immunization and the cost of reaching them. When we add some criteria like comorbidities, and in our part of the world, that is often involves hypertension, which has very high endemic levels. We also have obesity in some of our communities. We also have diabetes, we have asthma. So I aggregated some stats on that and said, if the age 50s and the people with comorbidities over age 50 are combined with people in younger age groups, what kind of population proportion are we going to have to reach? And that comes up to about 21%. And when you look at covering the cost of people over 50 or people with comorbidities, you'll see that there's a very substantial reduction from that baseline scenario of the total population down to at a high cost vaccine cost of around 12% of government health expenditure. So considerable reductions with it, and if one targeted effectively, hopefully not too much impact, at least in the short term, on morbidity and mortality. The other scenario that I've just that I omitted was a scenario where we speculated, what if we could achieve herd immunity through reaching 60% of the population? You'll see that it's still a relatively large proportion of government health expenditure, and a big basic number for a fairly small and pretty poor low and middle income country. So this, I think, started unpacking what was likely to be big and what was likely to be small, and as has already been pointed out, things like cost of vaccines and what we can do to manage that is obviously clearly critical, and targeting, as long as we can target well, maybe may deliver a lot of dividends. But it also highlighted where we just don't have good enough data, particularly on things like comorbidities. And in particular, this estimate left out people living with HIV, where we still, despite at this stage, don't have good enough data on relative risk of people living with HIV and to what extent we have to target them separately. So what came out as some key issues for sub-Saharan Africa and our prioritization? Is overall cost an issue, and how important is it to get cost effectiveness right in our context? I think those numbers show that at a country level, where we should be judging our interventions based on the trade-offs at country level, both cost and cost effectiveness are likely to be very important things to look at. And I think there's not only potential for substantial fiscal costs, but also there are a lot of opportunity costs obscured both by immunization and no immunization strategies that have to be factored into our more ambitious modeling of the options. I think one of the key things is to say, what are we comparing cost effectiveness to in our countries where we may have relatively low costs of inaction in terms of some analyses. We've got to make locally appropriate comparisons. So it's probably not necessarily adequate just to look at comparisons between COVID vaccination strategies, but we probably have to compare them to other immunization, which may suffer if we divert a lot of resources to COVID, and also new treatment options instead of vaccines, and possibly trade-offs on other services. I've mentioned some of the issues around targeting, where we really do need to accumulate priority data. And there are many key unknowns in Africa. To what extent is hypertension actually going to prove to be a significant comorbidity? Some of our early data suggests it might not be as powerful. What happens because of our age profile? What happens with HIV, etc.? I think we're going to have some quite specific questions and challenges in making sense of that data. I think also what we're finding, as we see in the US, is that there are many sub-epidemics with different risk contexts and subgroups and transmission dynamics, which may mean that we have to have different strategies at subnational level as we have outbreaks or potential outbreaks going forward. And then our strategy is probably going to change as we face different percentages of our population who are already exposed and immune. In a country like South Africa, where we're seeing really explosive growth of the epidemic, we may have a large proportion of the population who are exposed by the middle of next year, and that might also change the advice that we'd give.
Anthony, can you wrap up soon?
Okay, I mentioned, I stratified my analysis in terms of vaccine cost, but one could also say, well, high cost is like a highly constrained supply situation. And so that might be pushing us towards targeting as a much more important strategy, even if the price has been managed down in the short run. And then we've also got to take multi-year perspectives, including things like decay and immunity, into account as we help to make decisions. So I hope that this, I'll stop there, and I hope that this has illustrated some of the interesting issues that come up at a country level and a regional level as we start taking these strategic discussions into account. I think that they just emphasize that we really have to develop both epidemiological and economic models that can accommodate emerging data and chase the priority data. So thank you.
Thank you, Anthony. I think that's important for us to remember, that the opportunity costs of these scarce vaccination resources, the nurses and the clinics, is something that is going to be very contextually. Okay, let's have Awad Matria take the microphone.
Yeah, so thank you very much, David, and thank you, colleagues, for all the great insights that you had given. I would like really to start by thanking you, David, for involving WHO in this important discussion and bringing in aspects and issues that our region, where I serve, the Eastern Mediterranean region, we are faced with regard to the question of the vaccine and COVID at large. I think my first point is that if we want to make the vaccine available and that people make proper use of it and we benefit from the impact of that vaccine, then what is needed is to have an effective and equitable immunization strategy all over. So it's a strategy that would tackle all sorts of challenges that impact on the access to vaccine, as we have seen from other types of vaccines, but in particular in relation to COVID. So something that we are working on now in WHO EMBRO is to develop a regional strategy that gives a special focus and emphasis to COVID products, in particular COVID vaccine. And it's something that we hope we will be able to present to our member states in October to get their buying in and to get them give them the guidance on the way forward. Accompanying that strategy, or maybe as part of it, we think it is important to have a proper identification of adequate financing mechanisms and financing arrangements that would ensure the proper implementation of that strategy. And what I would like to present here is the importance of looking at that question of financing from the universal health coverage dimension. So it is about access, but it is also about financial protection, and it is about the quality of the vaccine and the quality of the impact that you would like to achieve. So to look at the question from an overall universal health coverage perspective, and to take a health system agenda or health system perspective, we would be faced with. Something that I think would be really important, and it is a learning that we are gaining from the current pandemic, is that all countries, maybe globally, but mainly in our region, have not given enough attention or did not invest enough in what we call essential public health functions, or what economists like to call the common goods for health. And within those common goods for health, something that is very important, the question of the vaccine, is the supply chain. So in our countries of the region, we see there is a lot of gap in relation to the supply chain. And that is an area where we would need to give enough attention and to call for sufficient investment in that regard. So for us, we think that in the way forward, this should be the step zero in the health system recovery, in building back better health systems and ensuring access to COVID therapeutics, COVID products, and COVID vaccine. And these essential public health functions can only be invested in through public financing. And unfortunately, in our region, so the Eastern Mediterranean region, we have been repeatedly emphasizing that as a region, we are not investing enough in health. I mean, the region counts for almost 9% of the world population, but is responsible for less than 2% of what the world is spending on health. And if we dig deeper, we find that this is mainly because there is low public investment in health. At the regional level, we are almost 2 percentage point less than what the governments are spending on health globally. Regionally, it is at the level of 9%. Globally, it is 11%. And again, digging deeper into the numbers, we find that this is not because of a lack of fiscal space within the different countries of the region, but it is because health has not been given its due and enough priority in the government allocation. So we are trying to tackle the issue from different angles, and now we are trying to replicate those messages and lessons to the question of COVID and COVID vaccine. And I'm really privileged to invite my colleague, Dr. Nadia Teleb, who is the regional advisor for vaccination and at large, and who has been working at the regional level on the question of COVID vaccine and how we are tackling the question of what has been mentioned about the COVAX facility at the level of the region. So Nadia, if you would like to shed light on this question.
Thank you, Awad. Good afternoon, everybody, and thank you for this opportunity. Anuradha has already talked about the COVAX facility, and I will mention something of the regional situation. Actually, so far, 10 out of our self-financing countries have expressed the interest to join COVAX facility, and 11 are AMC eligible. So 21 countries has already had some expression of interest in order to access vaccine through COVAX facility. As Anuradha mentioned, it will be around 20% distributed fair allocation through the COVAX facility. But the issue is at the country level, how this 20% will be distributed. It will be the responsibility of the technical advisory committee, obviously the National Immunization Technical Advisory Groups and related bodies to decide who will get the vaccine exactly. In addition to that, some countries are trying to access vaccines also through bilateral agreement with the vaccine manufacturers. So what would be the implication of this on overall vaccine supply and vaccine availability? This is also a point that should be taken into consideration. And definitely, as mentioned just now by Anthony, we don't know the price of the vaccine yet, and accordingly, or whether it will be 1 dose or 2 doses. So accordingly, what will be the overall implication cost-wise on our region, especially that it is most of the countries are not very rich, even those classified as upper middle income country. They have highly challenging situation, including Iraq, Iran, Lebanon, Libya, those classified as upper middle income, fully self-financing, but they are facing a difficult situation. So what would be the implication of COVID vaccine price on those countries? Thank you.
Thank you very much, Nadia, and over to you, David. Thanks. Thank you.
Thanks, Nadia. Our last speaker will be Bill Padula. Why don't you take the mic?
Thanks, David. Hi, everybody. I'm Bill Padula. I'm an assistant professor of pharmaceutical and health economics at University of Southern California. And I've given quite a bit of thought to this conversation about applying cost effectiveness modeling and thinking about opportunity costs in the frame of COVID-19, and thought I'd share some of those updates with you. In fact, Shrina Malavia and I and several other colleagues have a cost effectiveness study posted preprint right now on the SSRN Lancet server. So feel free to download that, noting that it's not peer reviewed yet. And we're still going through that process. But what we've learned about doing this cost effectiveness analysis of COVID-19 vaccines and treatments are severalfold. First, I'll comment on the point of opportunity cost that both David and Anthony have made before me this morning, that we have very few options to spend our money on right now in healthcare besides COVID-19 if we want to get our lives back to normal. Gary Becker, the Nobel-winning economist at University of Chicago, once estimated not too far ago in 2009 that just in the United States alone, the economic impact on our society for a pandemic could be in the range of about $20 trillion. That's much different than most of the diseases that we try to address on a daily basis. So from a US perspective, take $20 trillion, divide it by about 300 million people financed over a 3 to 5 year period, and you're looking at about the classic number of $100,000 per quality adjusted life year as the willingness to pay threshold, or the money that is best spent treating coronavirus rather than spent treating other things. And so we get back to this idea that coronavirus, it represents some of the classic thresholds in cost effectiveness analysis that we need to continue to consider. And some people might think that $100,000 per QALY, great, perfect threshold with which to build a cost effectiveness model and come up with a price to pay for a vaccine or a treatment. But it's not quite that simple, because anybody who does a lot of economic modeling knows that when you develop a cost effectiveness analysis, you always have comparators. What are our comparators right now to a vaccine or a treatment? Right now it's social distancing, wearing a mask, or frankly doing nothing, like some political leaders have reacted to. So we really have no good alternatives currently, making the introduction of a vaccine or a treatment economically dominant, or that is, it will ultimately save costs and increase health benefits as a result of being introduced to the world. The challenge is the hurdle that Dr. Gupta had mentioned before, where the supply chain and the upfront investment and budget impact in these vaccines could be tremendous, especially since uptake could be so fast, or everybody's demanding it all at once. And so I think what we have here is a conundrum where cost effectiveness analysis as a blunt instrument doesn't offer us much insight into pricing, but budget impact analysis does. And budget impact analysis simply puts us in a position where countries have to look into their wallet and see how much money they have, how much money they can afford to allocate to investing in a solution for coronavirus, whether it's a vaccine or a treatment, and moving ahead with dividing up that budget or that cost among all the people who would benefit from it. Where I do see that cost effectiveness analysis does have a real use to us is also something that Dr. Gupta mentioned and led off with, thinking from the Gavi perspective, in that we need to assess value between subgroups. Clearly, there are individuals or groups throughout the world, the elderly. In the United States, it's African Americans, people who are poor and have little access to good health care. These are the individuals who are most highly susceptible to coronavirus based on the early data we've seen. And therefore, the value that a vaccine or a treatment will have for a lot of people disenfranchised from healthcare systems will be greater than for the average population. And so cost effectiveness as a tool could potentially help us allocate resources for vaccines more efficiently to those who are of greatest need. And I think that's the good way to look at the balance between cost effectiveness analysis and other tools we have in economic evaluation, including budget impact analysis. So back to you, David.
Great, thanks, Bill. Glad to hear that there is a tool ready and a paper ready to guide us as we try to apply budget impact analysis. Maybe, Bill, you could put a link to the paper in the chat box. So we are asking our audience now to use the chat box for questions. And as you do that, I'd like the panelists, if you have some questions for other panelists, why don't you go ahead and take the mic and ask. Anybody? Okay. Well, then I will lead off. I see from Prashant's comments that we are facing a challenge of reaching target adult audiences that we have not done before. And this makes it hard for us to make estimates of what it will cost to target. Bill's comments say that different targets have different values based on their number of secondary cases, as well as their likelihood of dying and the number of DALYs averted in a special target. But in an unknown of what does it cost to target in my system, the prioritization is different. And maybe Prashant, you've thought of that. How do we multiply the cost of targeting? How do we estimate the cost of targeting? What can countries do to target? And maybe other panelists have thought about that too, but I'll target that to you first.
Thanks, David. And I think targeting and determining the additional costs that may result from, when I say additional cost, means additional cost per person immunized, that may result from targeting as compared to the birth cohort type of per unit cost that we have reasonably good estimates on. I think the challenge there lies in, do we know what the rules are? Do we know what subgroups are we targeting, right? So I think we will have to start with scenario type of analyses, because a simplified view of the world is we would target elderly, we would target healthcare professionals, we would target those with comorbidities. But from a transmission standpoint, there might be other subgroups that evolve, geospatial characteristics, where is the infection higher, and so on. So I think if we develop a few scenarios, then it comes down to asking the question, what economies of scale do we lose by a very targeted strategy? And what do we gain in terms of allocating a scarce resource to a specifically targeted subpopulation group? And that, that sort of cost-benefit analysis then lends itself to doing multiple scenarios that at least start giving us some ideas of where we may land, and at least create them before and with sufficient time and notice, so that when countries start thinking about this in a real make a decision tomorrow sense, we've already done some of that homework beforehand. So I think the tools exist. The key thing will be to know what scenarios to plan for.
Maybe Awad and Anuradha have seen countries getting ready to target and estimating the cost of finding their targets. Have they looked into ways to reach these special groups?
Yeah, so David, let me just sort of put this in perspective, right? One is having vaccines is one thing, right? But delivering them to those who need them the most is another thing, right? So to me, what we are looking at here is a very exceptional situation, where everybody is troubled by the pandemic, right? But even if you have safe and effective vaccines, it's going to be very scarce. The availability is going to be very scarce. So I think first is the politics of distribution and delivery that we have to understand. And to me, what we really need to ensure is a scramble, avoid a scramble for protection, for profit, and for patronage. So I think some of the things that Prashant referred to, so how do you pool? But, when you start to pool, it really is very difficult, because there are interests, that are at variance, so they're competing interests. So manufacturers might actually be scrambling to make maximum profit out of this adversity. So that is why I talked about, this whole common vision about a global public good. How do you sort of bring everybody to understand that, this is a situation that we need to address sort of jointly without sort of any politics or desire for patronage or a personal protection or disproportionate profit. The second observation that I would want to make is that there are too many unknowns here. So I appreciate the work that is going on, but we absolutely must understand that at this point of time, we are pretty much shooting in the dark. We don't have clarity on vaccine characteristics. So we know there are more than 100 now vaccine candidates that are looking, somewhat promising. Every day the figure changes, right? How many are entering the clinical trial stage, et cetera, et cetera. 9 vaccine candidates are being actively supported by CEPI, and we are trying to stay coordinated with CEPI. But of course, Gavi portfolio can be broader than CEPI supported portfolio of vaccines, right? So if they are supporting 9, we could actually have deals with more manufacturers, 18. There's nothing that stops Gavi from broadening that portfolio. But the point is, we do not at this stage understand, what would be the vaccine characteristics, what would be the efficacy of vaccines, how many doses would be required, whether it is going to be one-time vaccination or it is going to be like seasonal flu, right? And, so that there is certain new data that is coming out on antibodies, antibodies, the King's College a study that just came out last week, showing that antibodies start to wane, right, after about 3 months. So I think so the point that I'm trying to make is that, of course, we are trying to get prepared, but understanding that a lot of things would shift. Now on delivery strategies, I think that Prashant referred to, and some other panelists also touched on that. I think it is targeting is not a problem. I have worked in a country, right? And I've handled vaccination program and several other programs. It's not targeting, it is the intent that is important. So when we are talking about adult vaccination in Ebola, right, we actually went after health workers. So when Gavi sort of played a role in bringing forward Ebola vaccination, we knew that Ebola vaccination is not for everybody, right? It is for select groups, and in DRC and a few other countries, neighboring countries, we did succeed in having targeted vaccination. So on adult vaccination, we routinely vaccinate pregnant women. So I think a lot of focus is on childhood vaccination, but we forget that pregnant women actually have almost universal TT vaccination. And also when we do yellow fever and meningitis preventive campaigns, then we go up to 65 years of age. So to me, the issue really is that the delivery strategy would be determined by the vaccine characteristics. And in the beginning, the population groups that we are targeting. And after that, so we don't know whether the cold chain, the existing cold chain that we have for vaccines, 2 to 8 degrees centigrade is going to be good enough, or, it like Ebola vaccine, it is going to be minus 20 degrees. So if that is the case, then clearly it becomes much more complex and it would require additional incentive. So I would just really conclude by saying that what we need here really, both at the global level and the country level, is leadership, right? And leadership and integrity. Because, if that starts to happen, then a lot of these pieces would start to fall in place. Over.
Okay, thank you. In the audience, I see a question from Mohammed HUQUE dialing in from Tasmania. Mohammed, can you take the mic and use your voice for your questions?
Yeah, hi folks. It's Mohammed HUQUE from Department of Health, Tasmania, Australia. Look, my question is around the supply chain, because I don't think one single vaccine would do the trick. I think there will be multiple types of vaccine that needs to be utilized in order to tackle this pandemic for COVID-19, sorry. And how will the supply chain be managed? My other question, and this is something that has been triggering more and more in our health system in Australia. We were very lucky at the beginning by closing the border, and we suppressed the virus quite a bit. Now, unfortunately, Victoria, or one of our state, we had a massive resurgence of the virus, and the numbers are really going high now, which is a kind of a danger for us because our health system is not capable of handling it. On the other hand, if we go across the Tasman Sea, we see New Zealand has gone for the elimination approach, and they have really dropped it down quite a bit, almost to negligible numbers. What is your view if countries that are well off go for an elimination strategy rather than a suppression? Then they can actually manage their economy better. I mean, I think elimination is a much better option. Would you agree, or we may not get to the other end? I mean, if anybody can comment, that'll be great. Thanks.
It's a hard question. Any takers?
Maybe I can reflect on that, but also I want to touch upon the previous point that was raised by Dr. Gupta. I mean, great insights. I guess the question of whether we want to eliminate the virus or to contain it or to mitigate the impact of it, we have been seeing different country experiences. And as you mentioned, David, and other colleagues, I mean, this is a new virus and we are learning. Every day there is something new about the impact of different strategies and different types of approaches that countries have undertaken. I mean, some of our countries in the region have went for an elimination strategy, but through a very strict lockdown of the country. And now, I mean, no country can afford having lockdown for longer than what has been done so far. I mean, one good example in the region is Jordan, for instance, that has went into a very strict lockdown strategy. And they managed to sort of, until now, the recent days, to have no new cases. But I mean, there is a social pressure to open up, and even the airport, there are news now that it will open, and we don't know what will happen with regard to the hopefully not, but any resurgence of the number of cases in a way. So it's a balanced question between the public health impact and between the economic impact, without seeing the two as a dichotomy by any means, because one should support the other. But I also very much relate this to what Bill has mentioned in any economic evaluation exercise, because we want to have a comparator, and the comparator here is limited, or if it exists. I very much like what he referred to as in case of the economic burden of a pandemic. We might need to put all our resources in a vaccine or in controlling this pandemic, because otherwise there will be no development, no life beyond this level. So finally, I think we are trying also to do some simulation exercises at the regional level, and my colleague Nadia has been doing some estimations in terms of number of doses that would be needed, with all the unknowns that Dr. Gupta has referred to. So we have done estimation number of doses that would be needed for the if we only focus on the health workers, if we want to target the elderly or other risky groups, and we have some of those numbers. I think my very last thing at this point is that targeting would be useful if the principle or if the criteria for targeting is a simple one. So if it is an age criteria, if it is a special professional group. But if we go further than this, then maybe the cost of targeting itself would override or would supersede the targeting process itself by all means. And again, thank you very much, and it's a great discussion. Over.
Yes, Prashant.
Yeah, so by no means can I talk about the elimination question. It's above my pay grade, but I wanted to mention something related to the question that Mohammed posed on multiple vaccines. So I think it's important to recognize that I think we often start talking about a vaccine, but in reality, we may end up with a scenario where different population subgroups require different vaccines. And the supply chain and the scenario planning that we need to do needs to start getting ready for that state of the world, where it's not about we'll buy all our vaccine from one manufacturer, it'll have certain characteristics, we'll design a cold chain system for that characteristic alone. In reality, it may be that every country requires more than one. The second is a key point about cold chain equipment and getting ready to look at multiple scenarios. So I agree with Anuradha that there are so many unknowns, but at the same time, I keep reminding us that the world of health economics is about decision-making under uncertainty. And I think we all can do our own little research, but my hope is that the iHEA community can say, here are a set of scenarios that we all collectively want to look at. And then we can all do specific research around the cost of targeting, precise targeting, somewhat more broader blanket targeting, things like that. So anyway, that's just a plea I'm making to you, David, that if the community as a whole can think about what are the unknowns and how do we capture them in appropriately designed scenarios, then I think we will be able to move forward quickly by putting all of our collective modeling and other analytical tools to bear.
Anuradha, and then Anthony.
Yeah, so Prashant made a very good point, and I think I hope I did not convey an impression that we should not be acting or preparing. I think, but staying cognizant of the political economy and unknowns can help you strategize better and do mitigation, good mitigation in time, and that is what I was highlighting. But I just do think that we need to, and this is actually the work that we all are collectively doing. So Gavi and WHO and UNICEF, we all are doing scenario planning, saying, okay, these are the different technology platforms, these could be the likely vaccine characteristics, and then what would be the regimens to administer, and how do we do targeting, and what is the technical guidance. So a lot of work is already underway. But I just do think that it is important for us to build up economic arguments which would help persuade country governments to actually stay targeted and focused. Because I can easily imagine a scenario where, because of scarcity, vaccines actually protect those people who probably need the protection the least, right? And that is why I think just for the leadership to recognize the risks that obtain if the highest risk populations are not covered in the first phase would be a very, very important exercise. And the second point is that our entire ambition, because Gavi is now wanting to actually support 90 countries, 90 countries, which we think would not have the ability to pay for this vaccine, right? But for that, we need donor support. So donors have to step forward. And the projection that we have made for just 1 year by way of vaccine costs is more than $5 billion. So the point is, if that's the projection, and with delivery costs, our projection for 1 year is $8.7 billion. So the point is how do we make a business case for donors to agree to actually provide that supplementary financing to Gavi, so that with our partners, we can actually take this vaccine to those countries which would not have the purchasing ability. Over.
Thanks, Anthony. And last question, I guess I see one from Joe Millward. I'd like the panelists to get an answer ready about vaccine hesitancy. Is this something that you think will be a big problem? So Anthony, and then somebody to talk about vaccine hesitancy, and then close.
I think a point that flows from what Prashant and Anurita have just said is that we've got to be careful about doing localized affordability and cost-benefit analyses, because essentially because it's such an infectious virus, what we do has either externalities or public good effects that we need to build into our analyses and be responding as a global community rather than individual countries. So I think that's a bit of a challenge to some of the economics. But I think what that points have also raised is that our experience with the HIV epidemic was that politicians were very bad at understanding scenario planning. And to be frank, our own colleagues in the health sector were not good at making decisions based on different scenarios and managing risk. So I think that what we can usefully do at the moment is help our politicians to start thinking in a sort of scenario planning way to deal with the uncertainty which is likely to persist.
Okay, so our last question from Joe Millward relates to vaccine hesitancy. Will this be something that economics can shed light on? So the points we were raising about some vaccine nationalists saying, look, I know I'm only supposed to get 20%, but I'm on an island, I'm gonna go for elimination. Anthony's saying, well, sorry, I'm not sure you're so protected. And if there's vaccine hesitancy on that island, it'll never work. But I guess that's gonna go along our list of the unknowns. Any closing remarks from the panelists?
Maybe
okay, well,
one
yes, go
point,
ahead.
David, very quickly. I guess, we are talking here about the vaccines and looking at it from health economics point of view, which is very important, very pertinent. But we should not forget that this should be one element of an overall public health strategy for addressing the pandemic. Hopefully we'll have the vaccine soon and it will help us curb the epidemic curve. But the other public health measures that we have been promoting and countries have been implementing are very important. We need to keep reminding people of the importance of those in order to face this unfortunate pandemic. Thank you very much.
Great, so I'd like to thank all our panelists, thanks to the audience. We can continue this discussion in the special interest group. If you join iHEA, we have a thriving social network presence, and we need to stay as a community focused on our role as economists in helping with the coming crisis, as well as the solution, which will roll out soon, and we hope to play a part in avoiding the chaos and pandemonium that might happen if our worst elements of human nature take root. So I'd like to wave goodbye and thank everybody for coming, and we can see this again on recording. Bye.
Thank you.
Thank you. Bye-bye.
Thank you.